Good morning, everyone. Today, I'm Dr. Bandana Khanal. Today, I'm going to discuss the topic of heart disease in pregnancy. It's a very lengthy topic, but I've tried to cut it short. And we're not going to discuss each and every cardiac disease in pregnancy because at your level, only the general management of heart disease in pregnancy is required, and you should know the salient features of some cardiac diseases. As we all know, pregnancy places the normal heart under immense strain, and the onset of pregnancy, it marks the beginning of progressive and profound changes in the physiology of the cardiovascular disease. If the heart is already compromised by an existing disease, it can result in a poor maternal and fetal outcome. And pregnancy in a patient with cardiac lesion should be carefully planned and monitored. As we all know, heart is a very important organ of our body. Any patient with any pregnant lady with heart disease, she should be monitored carefully, and the pregnancy should be planned carefully. And serious maternal cardiac disease complicating pregnancy is relatively uncommon, and the overall incidence being around 1%. And significant adverse effect there we have seen significant adverse effect on the maternal and fetal outcomes despite the modern cardiac care. Now, coming to the specific cardiac diseases in pregnancy, which are well tolerated or poorly tolerated, the lesions like mitral regurgitation, aortic regurgitation, ASD, PDA, pulmonary stenosis, hypertrophic obstructive cardiomyopathy, these lesions are usually well tolerated except if they progress to Eisenmenger syndrome. These lesions are able to tolerate the increased volume during pregnancy. And the lesions, following lesions, the pregnancy is poorly tolerated, and if possible, these patients are asked not to get pregnant or avoid pregnancy. The lesions are listed here. Obstructive diseases like mitral stenosis, aortic stenosis, coarctation of aorta, cyanotic diseases like any previous mentioned lesions with Eisenmenger syndrome, that is left to right shunt, and primary pulmonary hypertension and teratology of Fallot. These cyanotic heart lesions, pregnancy is best avoided. And volume-limited diseases like Marfan's with aortic root involvement, aortic dissection, active rheumatic carditis, any lesion with class 3 or 4 symptoms. I'll come in the next slides. What does class 3 or 4 symptoms mean? Now, coming to the cardiovascular changes in pregnancy, pregnancy causes profound anatomical and physiological changes. Talking about the anatomical changes, there will be lateral shifting of apex bit because there will be apparent cardiomegaly, and it can be well seen in chest X-ray with evidence of elevated. Why there is apparent cardiomegaly? Because there is elevated diaphragm. It pushes the heart upward and somewhat rotated. And the normal pregnancy might also have some degree of pericardial effusion. There will be slight left axis deviation in ECG, and there will be exaggerated splitting of first heart sound and audible third heart sound, and there will be presence of ejection systolic murmur. So if there is ejection systolic murmur in a pregnant lady, you should not worry much, but we cannot let her go by saying that this is just a physiological murmur. We have to do investigation and find out whether it is a normal thing or not. Okay, then coming to the cardiovascular physiology, I think these things are already taken in detail in Physiology of Pregnancy, but I'm just going to give the overview. There will be increase in cardiac output in most, and it is the most significant change seen in pregnancy, and the rise starts from first trimester, steadily rises to peak at 32 weeks by 30 to 50%. So this is a huge overload on the heart, and cardiac output is normally 4.2 liter per minute. And it is increased to around 6.5 liter per minute at 8 to 10 weeks of pregnancy, and then remains so near till term. Now, what are the causes of increased cardiac output? In early pregnancy, increase in stroke volume, it causes the increased cardiac output. In late pregnancy, increase in heart rate, it causes the increased cardiac output. And decrease in systemic vascular resistance. I'll let you know in coming slides why there is decreased systemic vascular resistance. And also due to decrease in blood viscosity, there will be increased cardiac output. Decreased systemic vascular resistance, SVR, it is due to trophoblastic invasion of the endometrial vessels that are present in the placental beds, and these placental bed blood vessels, they are converted into a huge pool of blood, and they serve as the large AV shunts. And there'll be also increase in level of prostacyclin, nitric oxide in pregnancy, which causes the decreased sensitivity of the blood vessels to the vasoconstrictor agents like angiotensin, that is mainly seen in pregnancy. And this decreased systemic vascular resistance, it is required for the proper blood flow to the fetus so that the fetus flows normally. These are the normal physiological changes that ensure that the baby is growing properly. And as we all know, progesterone, a pregnancy hormone, has got a vasodilatory effect. Also, there will be pulmonary capillary wedge pressure and central venous pressure. They don't change appreciably, and although cardiac output is increased, left ventricular function as measured by stroke work index, it remains similar to the non-pregnant normal range. So what are the things we knew? What are the things that remain changed in pregnancy? Now we'll see what are the things that remain unchanged during pregnancy: mean arterial pressure, central venous pressure, pulmonary capillary wedge pressure, and left ventricular stroke work index. As I already said, they will remain unchanged. And as we all discussed previously, systemic vascular resistance, peripheral vascular resistance, and colloid osmotic pressure due to the causes of hypoalbuminemia, they decrease. And we already discussed cardiac output, blood volume, heart rate, pulse rate, they all increase during pregnancy. There is something called as supine hypotension syndrome. It is seen in around 10% of the women. It is due to the supine compression. When the lady lies there in a supine position, there will be supine compression of blood vessels by the uterus that causes significant arterial hypotension. That's why, and there will be decreased blood flow to the fetus. That's why we ask the ladies, preferably they should lie in left lateral position or any lateral position, not the supine position. We talked about the prepartum or antepartum hemodynamic changes. Now we'll come to the postpartum hemodynamic changes, and these changes are, we have to know these changes because according to this, we have to plan the pregnancy and the delivery and postpartum management. These are very important for the antenatal, intranatal, and postnatal management. Postpartum hemodynamic changes, they comprise, they are mainly due to the blood loss during delivery. There will be temporary increase in effective venous return due to the relief of cable compression and autotransfusion. Autotransfusion, why? There will be, because there will be a closure of the sinusoids that are present in the uterine vessels. The changes, they persist for a few weeks postpartum, and it may take up to 12 to 24 weeks for the parameters to return to normal. So hemodynamic changes postpartum. This is a chart which indicates hemodynamic changes. Blood volume, it decreases because of the blood loss. Cardiac output, it increases 60 to 80% immediate increase followed by rapid decrease and returns to normal level in few weeks. Stroke volume, it increases. Heart rate, it decreases. BP remains unchanged, and systemic vascular resistance, it increases because there will be loss of low resistance placenta. And all the hormones that are causing all the factors that are like nitric oxide, prostacyclins, they all are withdrawn from the body as soon as the baby and the placenta is delivered. Coming to the effect of pregnancy in cardiac disease. There will be marked cardiovascular changes that lead to profound effect on heart disease. As we all know that pregnancy is a state of hyperdynamic circulation. So a damaged heart with good reserve can withstand the strain, but if the reserve is poor, cardiac failure might occur. And the most crucial time for the cardiac failure, or most crucial time when we have to monitor the ladies during antenatal period or intranatal period, is around 30 to 32 weeks of pregnancy. This is the peak time when the blood volume increases to its maximum. During labor, because she'll be in strain and she'll be hyperventilating, and at this time the cardiac overload increases and she might go into failure. And soon after delivery, because of the pooling of blood in the systemic circulation, she might go into cardiac failure. Other factors that are responsible for cardiac failure are if she is old lady who's giving delivery, who is delivering the baby, or there are any history of cardiac arrhythmias or left ventricular hypertrophy as evidence in echocardiography, or there is history of previous heart failure, then it's more likely that she will go into cardiac failure. What are the risk factors that can precipitate the cardiac failure, like presence of infection, anemia, hypertension, excessive weight gain? All these factors, they lead to hyperdynamic circulation and they might precipitate cardiac failure. Other factors might be multivitamin pregnancy, inadequate supervision during pregnancy, drugs like beta mimetics, excessive intake of caffeine, alcohol, high calorie diet. These all might precipitate cardiac failure, and you have to be very careful on antenatally monitoring the patient with cardiac diseases. Now coming to the effect of heart disease in pregnancy. So what will heart disease do to pregnancy is there are tendency for preterm delivery and prematurity. Preterm delivery might be iatrogenic or spontaneous. Iatrogenic, yes, if we terminate the pregnancy, if we feel that continuing the pregnancy will deteriorate the mother's condition, maternal condition, then we go for preterm delivery. And when preterm delivery occurs, there are chances that the prematurity, baby will be premature, and the outcome of the baby will not be so good. Intrauterine growth restriction is mostly seen in cases of cyanotic heart diseases because of less blood flow, less oxygenated blood flow to the fetus. Very important part in cases of heart disease is those patients with heart disease who want to get pregnant. Preconceptional counseling forms the mainstay of management because these patients have to be counseled on various aspects regarding pregnancy, delivery, the use of medicine, everything they need to be counseled. Okay, classification of the heart condition has to be done, or functional and risk assessment has to be done. We have to explain about the effects of cardiac condition in pregnancy and effect of pregnancy in cardiac conditions. And fetal and neonatal complications associated with a specific heart condition has to be explained, because in cases of cyanotic heart diseases, she might need to terminate the baby earlier, or she can go for abortions, or she can have, if the baby continues to grow without worsening her condition, then baby might be in intrauterine growth restriction. Need for multidisciplinary care, like the use of involvement of obstetricians, intensivists, and cardiologists together during her antenatal, internatal, and postnatal period. She should be explained that she has to frequently do the antenatal visits, and there is a need for maternal and fetal testing, and you have to explain that her antenatal, internatal, and postnatal management will be a bit costlier than the other ladies with normal pregnancy or not with cardiac diseases. You have to explain about the need for anticoagulation and hemodynamic monitoring, timing of birth, type of hospital facility required for childbirth has to be explained properly. Pain control and type of anesthesia is required during labor and delivery, because pain control forms an essential part, because due to excessive pain, she can go into cardiac failure. And potential need for cesarean delivery, it also needs to be explained to her. Other important considerations that need to be made are time and facility of delivery, and the drugs that are used postpartum and the effects on breastfeeding has to be explained properly, because the ladies who are started on cardiac drugs, they'll be very worried about whether the baby will be affected by the drugs they are using. So breastfeeding forms, counseling for breastfeeding and the effects of drugs forms the mainstay of management. Now, coming to the, like I've already said in previous slides, Eisenmenger syndrome, severe left to right stenosis, or Marfan syndrome with dilated aortic roots, these patients are best to avoid pregnancy because there are high risk of maternal death, because there will be high risk of cardiac failure during the antenatal period. Now, coming to the NYHA classification of cardiac diseases. What is NYHA? It is New York Heart Association Functional Classification of Cardiac Disease. Class 1, 2, 3, 4. Class 1 is there is no functional limitation of the activity. There are no symptoms of cardiac decompensation with activity. You have to be thorough with this classification, because while seeing the patients antenatally, you have to classify them. You have to tell them the risk factors that are associated. You have to counsel the patient about the timing of admission. You have to counsel them about the mode of delivery. So this functional classification is very important. Now coming to the class 2, there is mild amount of functional limitation. Patients are asymptomatic at rest, and ordinary physical activity, it results in symptoms. So mild ordinary physical activity, it results in symptoms of dyspnea, orthopnea, etc. Class 3 is limitation of most of the physical activity. They are asymptomatic at rest, but minimal physical activity, it results in symptoms. Class 4, severe limitation of physical activity, it results in symptoms. Patient may be symptomatic at rest or heart failure at any point of, they can go into heart failure at any point of pregnancy. There is some limitation of NYHA classification, that is, it only considers the symptoms but not the anatomical type and the severity of the pathology. So it does not predict the pregnancy outcome. So anatomical classification is also very necessary while counseling the patient. Now coming to the prognosis, what are the prognostic factors? The maternal factors that decide the prognosis of the cardiac lesion is the nature of the lesion, functional capacity of the heart, quality of supervision during antenatal, intranatal, and postnatal periods, and appearance of aforementioned risk factors like anemia, multifetal pregnancy, infection, etc. Maternal mortality is the lowest in cases of rheumatic heart lesions and cyanotic heart diseases, and account for less than 1% of the maternal mortality rate. With cyanotic heart diseases, with the elevation of the pulmonary vascular resistance, mortality can be as high as 50%. So with the diseases, which I've been telling you repeatedly, the diseases with cyanotic, the ladies with cyanotic heart disease, they have to avoid pregnancy if possible. And most of the maternal mortality occur due to the cardiac failure and after delivery. Immediately after delivery, it is a very crucial time you have to monitor the patient. What are the other causes of death? Pulmonary edema, pulmonary embolism, active rheumatic carditis, subacute bacterial endocarditis, and rupture of the cerebral aneurysm and coarctation of the aorta. These are the causes of maternal death. The fetal prognosis depends, it's usually good. It is not different from that without the disease. And cyanotic heart, in cases of cyanotic heart lesions, there are chances of increased fetal loss due to abortion, prematurity, and intrauterine growth restriction. I've already explained that. And fetal congenital cardiac diseases is increased by 3 to 10% if either of the parents have congenital lesions. What are the challenges in diagnosis of heart disease in pregnancy? The ones who have pre-existing heart disease, they are not the challenges in diagnosis, but those who present to you in pregnancy and you never know the cardiac status, these are the those ladies give us a challenge to diagnosis. Like anatomical, and why there are challenges in diagnosis is that because of the anatomical and physiological changes that mimic the cardiac disease, like hyperdynamic circulation, systolic ejection murmur at the left sternal border. It is due to increased blood flow across the aortic and pulmonary valves. It is seen in normal pregnancy. Dyspnea, decreased exercise tolerance, fatigue, syncope, they are all symptoms of normal pregnancy as well. Tachycardia, shift of ventricular apex, and you can also find out in normal pregnancy continuous murmur at the 2nd to 4th intercostal space, that is also called as mammary shuffle, and loud first sound with splitting can also be seen in pregnancy. So careful assessment has to be done to confirm the diagnosis. These 4 or 5 points which I have mentioned above, these make us this pregnancy, normal pregnancy findings that make us difficult to diagnose the heart disease in pregnancy. So diagnosis of heart disease in pregnancy, how do you do it? Symptoms like breathlessness, nocturnal cough, syncope, and chest pain. And the signs of chest murmurs, chest murmurs like pansystolic, late systolic, or diastolic, and which are associated with a thrill. These murmurs, if you find out on normal examination of a pregnant lady, they have to be subjected for further investigations. Cardiac enlargement with arrhythmia, that is seen in chest X-ray, chest radiography. You can, if you have any doubt, you have to come to a diagnosis. Applying lead shield after first trimester of pregnancy, you can do the chest radiography. You can see cardiomegaly, increased vascular markings. Enlarged pulmonary veins can be seen. In ECG, T-wave inversion is seen, biatrial enlargement can be seen, and dysrhythmias can be seen. In echocardiography, structural abnormalities, anatomy of the heart, left ventricular ejection fraction, most important parameter to be looked in echocardiography that defines how well she can tolerate the pregnancy and the delivery outcomes. Pulmonary artery systolic pressure, all can be measured in echocardiography. Very rarely you have to go for cardiac MRI because if you cannot find out the complex lesions which are not detected by echo. Now coming to the principles of management of heart disease in pregnancy, very important part now coming to. Early diagnosis and evaluation of the anatomical type and the functional grading has to be done. Detection of the high risk factors and prevention of cardiac failure. Detection of high risk factors like infections and anemia has to be done very quickly, and prevention of cardiac failure. Combined approach for the care and mandatory hospital delivery. Antenatal care. Combined approach, as I already said, combined approach by cardiologists and obstetricians. Injection benzathine penicillin every 4 weekly throughout pregnancy, and puerperium to prevent recurrence of rheumatic fever. These days, rheumatic fever or rheumatic arthritis have, the incidence has come lower than the incidence of congenital heart disease. Because of control of infection, the rheumatic arthritis has the incidence has been lower. Counseling to be done regarding prognosis and risks of the cardiac pertaining persisting cardiac disease. Special care in each antenatal visit to treat the risk factors that precipitate cardiac failure in pregnancy. She has to do frequent antenatal visits and admission in NYHA class 3, and as soon as the pregnancy is diagnosed, they have to be admitted. Now, guidelines for the management: avoid excessive weight gain, edema. You have to take low sodium diet, rest in left lateral position, and adequate sleep has to be confirmed. Avoid strenuous activity because that gives a load on the heart. Avoid anemia. Now, coming to the role of anticoagulants. Anticoagulants are usually given in cases of congenital heart disease with pulmonary hypertension, any patients with previous valve replacement, and in cases of atrial fibrillation. In these three areas, there are a role of anticoagulants. As soon as the pregnancy, if she is taking warfarin, as soon as the pregnancy is diagnosed, confirmed, stop the warfarin because it crosses the placenta and it causes warfarin embryopathy. Heparin is given up to 12 weeks. Then after that, warfarin after 12 weeks, we switch over to heparin, warfarin up to 36 weeks. And then again, heparin is started up to 7 days postpartum. And after 7 days postpartum, we have to continue the warfarin. You have to monitor the coagulation parameters when the patient is in warfarin or heparin. For early detection of a problem, because it's very necessary during the management. Why is it necessary? Because if we detect the problem early, we can prevent cardiac failure. In each visit, you have to look for infection, anemia, cardiac signs of cardiac decompensation, pulmonary congestion, cardiac arrhythmias. You have to look for them. And cardiac decompensation is indicated by tachycardia, engorged neck veins, increased in JVP, enlarged liver and spleen, and tenderness over those areas, weight gain, and generalized edema. These indicate the cardiac decompensation. Treatment is by diuretics and desensitization. Now, coming to pulmonary congestion, what are the signs of pulmonary congestion? Dyspnea, orthopnea, pulmonary crepitations on examination, decreased vital capacity, and it mostly appears at 18 to 24 weeks of pregnancy, during labor, during delivery, and immediate postpartum. These are the periods where we have to be very careful. Electively, when do we admit the cases? Grade 1 and 2, that is NYHA class 1 and 2 at 22 weeks, at 28 weeks of gestation. Grade 3 and 4, as I already said, as soon as the pregnancy is diagnosed, or at least 2 weeks prior to ED. Management during labor, place of induction. What is the role of induction for initiating labor? Most patients, they go into spontaneous labor and deliver without any difficulty. Induction may be employed in very selective cases with vaginal PGE2 gel for obstetrical indications. Management of labor, there will be increase in cardiac output. Cardiac output is increased by 40 to 50% of pre-labor level and 80% of pre-pregnancy level. So there will be a huge increase in cardiac output, huge increase in cardiac load. So because of the increase in catecholamine release, pain and apprehension, and abdominal and uterine muscle contraction, there will be increase in cardiac output. So first stage, patient has to be kept in left lateral position to minimize the aortic cable compression. Oxygen to be administered if required. Analgesia, very preferably epidural analgesia. Fluid should not be infused more than 75 milliliter per hour to prevent pulmonary edema. Careful watch of pulse and respiration. Cardiac monitoring and pulse oximetry can detect arrhythmia and hypoxemia early. CPP may be needed in selective cases. Prophylactic antibiotics, very important. They have to be started during labor and 48 hours postpartum to prevent puerperal endocarditis. Recommended regimen is ampicillin 2 gram plus gentamicin 1.5 milligram per kg, not to exceed 80 milligram at the onset of labor and 8 hourly thereafter. All high-risk patients with structural heart disease, complex cyanotic congenital heart disease, prosthetic valves need endocarditis prophylaxis. Very important statement. Now coming to the second stage, you have to cut short the second stage. You have to avoid maternal pushing. You have to curtail the second stage short by either applying vacuum or forceps, and avoid IV ergometrin, because ergometrin will cause sudden cooling of the blood in the systemic circulation, and that will give more cardiac overload, and the patient might go into failure immediately. Now coming to the management of third stage. Third stage usually active management of third stage is usually done to prevent the blood loss, but in cases of cardiac disease, some amount of blood loss is desirable, so conventional management is done. So we wait for the placenta to be removed, placenta to expel out by its own. But if you see excessive blood loss, oxytocin can be infused, given by intravenous diuretic, because you cannot overload the heart. Now, what is the place of cesarean section? Cardiac indications, coarctation of aorta, apart from other obstetrical indications, the specific cardiac lesions that necessitate cesarean section are coarctation of aorta, acute intractable heart failure, severe aortic and mitral valve stenosis, aortic dissection or aneurysm, aortopathy with aortic root more than 4 cm, warfarin treatment within 2 weeks. Puerperium, how do we manage the puerperium? She needs to be closely observed for 48 hours. Oxygen has to be given hourly pulse. BP and respiration recording should be done. Diuretics, if you see any signs of fluid overload. Breastfeeding is not contraindicated unless there is failure. Anticoagulant therapy is not a contraindication for breastfeeding. Now coming to the contraception, these patients, when you are discharging home, they need to know about the contraception. Steroidal contraceptions or preparations are contraindicated because of the fear that they may precipitate thromboembolic phenomenon. IUCD is avoided for fear of infection, but these days with the treatment of infection, this is not absolutely contraindicated. Progestin-only pills or parenteral progestins are safe but might cause irregular bleeding. So when you are giving progestin-only pills, you have to counsel the patient that she might have regular spotting PV and she should not be disturbed with that. Barrier contraception, if can be used effectively, is the best mode of contraception in patients with cardiac diseases. Sterilization to be considered with the completion of the family. Now, management of cardiac failure in pregnancy, she has to be kept in proper position. Oxygen administration, ECG and pulse oximetry monitoring, diuretics, mechanical ventilation if required, injection morphine, degoxing if you see any dysrhythmias, quinidine or electrical cardioversion, or tachyarrhythmias if seen, adenosine or dizzy cardioversion has to be done. Cardiologists are very necessary during labor, delivery and postpartum period. Now coming to the summary, and this is the most important slide. Summary of obstetrical management, close maternal and fetal monitoring, limit the pelvic examination for fear of introducing infection during labor, vaginal delivery preferred under obstetrical indication for cesarean section, shorten the second stage of labor by vacuum or forceps, avoid maternal pushing, no ergometry because some amount of blood loss is desirable, no uterine massage, again some amount of blood loss is desirable, and small postpartum hemorrhage we can allow for it. But if there is excessive amount of blood loss, then you have to give oxytocin infusion with concurrent administration of diuretics. Thank you so much for being with me. I think you have come to know a little bit about the cardiac disease and management. Management forms the mainstay of treatment management during labor, and postpartum period forms the mainstay of management, because these are the times when we might suddenly lose a patient because of cardiac failure. Thank you.